Primary care is important no matter where you live. Prairie Docs to midwives, the changing face of rural medicine, tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Many of our current treatments and therapies have roots that go back a long time. Some were out of vogue for years and are returning. Others have been with us a long time. First, let's take a look at this week's Prairie Doc quiz question. What percentage of deliveries by nurse midwives take place in a hospital? A, 20%, B, 95%, C, 50%. What do you believe is the percentage of nurse wife deliveries in hospitals? We will have the answer at the end of the show. Well, joining us tonight are Kathy Dean, a certified nurse midwife from Wessington Springs, and Dr. Tom Dean with Horizon Healthcare Incorporated, also in Wessington Springs. Thank you both for joining us.
Thank you.
So I thought this was a great opportunity. You know, the story, this whole program is called On Call with the Prairie Doc, and I kept thinking, who is a more of a Prairie Doc than me, and maybe it is you. And the story of your having worked with him side by side together in a home, the community of Wessington Springs all these years, delivering babies. You know, then it's just such a beautiful story. I just thought, we've got you. Why not take an opportunity to spend some time with you tonight? Kathy, tell us a little bit about how you got started. What was the story of this character? When did you meet him?
Well, we met at the University of Washington in Seattle, where he was a family medicine resident and I was a assistant head nurse in the labor and delivery unit. And we got to talking one day and I said, you know, I would really like to do more with my nursing career, but I just don't know what. And he said, why don't you be a midwife? And I said, oh, they still have those? And yes, he had spent a year in England in medical school, so he knew about midwives. And that's how I got the idea. So I thank him for that.
And it wasn't very long after that you were married? Or
and then we got married in the next year, and then we moved to Kentucky, where I enrolled in the midwifery program at the Frontier Nursing Service in Hyden, Kentucky, a very rural community in the mountains of eastern Kentucky, which was set up to provide maternity care to women who had no access
to health care, and had the worst. And they picked that area because why?
Because it had the highest maternal and infant mortality rate in the country at that time.
Wow. And
they very isolated county in the mountains of Kentucky. Yeah.
Very poor.
Very poor.
Lots of poverty. So, and then you went to practice there? I mean, you had finished your residency?
I finished residency in family medicine in Seattle, and then I had a commitment to the National Service Corps, and so we were looking around for a place where I could fulfill that commitment as well as Kathy could do midwifery education, and it turned out this was the place, and it worked out very well. So very interesting place.
Yeah, right. Your home, though, is originally?
My home is in I grew up on a farm west of Wessington Springs. So I wandered around the world for about 15 years, and I found a wife in Seattle, and then we ended up back in Wessington Springs in 1978.
So you, and that's interesting. You were, of course, I know Wessington Springs because I had a great buddy whose family, his grandparents were in Wessington Springs, and then he had aunts and uncles from up on the bluff west of Wessington Springs. Okay. I mean, so you're right on the bluff. There's a great story about Wessington Springs.
Right in the hills, yeah.
What is the story of that community and the bluff?
Well, I wonder.
I heard something about horse rustlers hiding in horses in the hills.
The hills have supposedly been a meeting place for traders and native folks and so forth that were traveling through, because there was always water and there was always shelter there. And in that area, especially as you go west of us,
there's nothing.
There wasn't any trees and there was no water, but there are trees and water, and it's always been there. And the town was named for the springs and still relies on springs to provide water for the community.
Yeah, great.
So
then you were out there. Let's hear about the Kentucky story.
Yeah.
You were out there how long?
We were there for 3 years. My program was 24 months, but we stayed for 3 years. And I took the basic nurse practitioner courses and then advanced along the program to the midwifery, which included family planning, women's health care, physical exams, and then labor and delivery, family planning, newborn care. And then we decided we wanted a place to live, and so we thought of Tom's home in Wessington Springs or my home in Western Washington, and well, we took South Dakota.
And are you happy that you did?
Very happy that I did. I grew up in a I lived in the city of Seattle for a while, but grew up in a semi-rural area, and I didn't realize how much that really meant to me. I always thought I wanted to be a city girl, but it's been a wonderful life there, and so.
Someone would say that, I dragged a Floridian back to South Dakota, and everybody asks from Florida,
sure.
You would go back to South Dakota? So yeah. I think that it's an interesting story that you two would move to South Dakota and live here for this many years and practice together. Has that, and you're a family physician. Let's talk about family practice, Tom. Has that been a rewarding, what is family practice, and how rewarding is that for the community, and how rewarding is that to Tom Dean?
Well, family medicine emerged about the time I finished medical school in the mid-70s as a new specialty, with the belief that the society needed to recognize the value of a physician who was willing to see the whole family. And before that, we had various other specialties, but there were none that all the specialties were either focused on a particular disease or a particular age group or something. And so the powers that be established a specialty board and established family medicine as a fully recognized specialty. But that was when I finished finished medical school in '72. There was only about I think about a dozen residencies in the whole country. Now there are hundreds, but I ended up in Seattle because it was the first one that was really integrated into a major university, and I was attracted to that. So
I would ask as an aside, and that we have a family physician, family practice residency in South Dakota. Now I have heard that it is highly regarded.
Absolutely.
What do you know about it?
Everything I haven't had a lot of direct involvement, but I know the folks that the faculty there, and everything that I know that it's a very, very highly regarded program. And the folks there tell me that what is really gratifying is that the quality of the students that they're recruiting has steadily improved. Not that it wasn't good to begin with, but they say now the students that they're getting are the very best that they've ever had. Yeah. They're getting the cream of the crop. Yeah. So that's something that I think is both we can be proud of, but more importantly, it means that it's bodes well for the future of the state.
Right, for the future of the state and primary care, which is so important. We can talk about the value of primary care, but I want to talk about the training of nurse midwives. But what were you going to say?
I was just going to say, I would like to speak to life in a small community and providing health care to people in a small community.
Well, let's hear it.
Well, I'll tell you. I go to school concerts, and I see the children
that you delivered.
Of the mothers that I was, they delivered their babies.
Kathy
I was there
to
to help
correct
them.
Me. I said, she did the delivery. She says, no, the mother does the delivery. I'm just there to help.
Yeah. and I've had little children come up to me and say, were you my midwife? And they knew the word.
Yeah,
it's very, very, very rewarding to watch the families grow and to realize that I was an important part of their life. I wasn't just the person that caught the baby.
So
it's a joy.
So there's an interesting group, though, because midwives aren't always well-trained, well-certified RN. I mean, you're an RN certified midwife, and you delivered almost all of your babies in the hospital.
Oh, yes, yes.
Now there's also non-nurse midwives that are certified and well-trained.
That's
and,
right.
And then there are non-certified.
Yeah, well, our state, or our national organization, the American College of Nurse Midwives and Certified Midwives. Some go to nurse midwifery school, and some go to a midwifery program that it's not, you don't have to be a nurse first. But they're both have to pass certifying exams and be licensed. It's the state that licenses the midwife. The national organization sets up the educational goals.
Okay. But there's still midwives that aren't even certified.
I'm sure there are.
And they're practicing in South Dakota?
I don't know that for a fact.
There's a lot of a trend to go to home delivery nowadays. It always makes me extremely nervous.
It does me too. I had dealt with people who come to the clinic and wanted to have home birth, and I said I really was not in favor of that, and I provided we do everything that we could to make the birth experience in the hospital as home-like and as flexible and warm and cheery as possible. However, some people wanted to stay at home, and they had their mother or a friend.
So what do you say about the danger, I mean, when things go wrong? I mean, it goes wrong fast. I mean, why are you in favor of being in the hospital?
Because you have access to emergency medications, emergency procedures, another nurse to help, a physician to help. There's more of a team in the hospital. Everything is at hand, and so I felt more comfortable with that.
It provides the patient with the most safety.
That's right, that's right. All the backup that could possibly be.
All right.
I think midwives are known for taking a non-interventionist approach. So their whole approach is to try to be as, well, non-interventionist. At the same time, I think they understand that there are times in obstetrical care where intervention is crucial. And oftentimes there are things that come up in a hurry and you don't have a lot of warning, and that's the value of having a hospital facility and having the things Kathy was just talking about.
I think another thing to keep in mind is that in our practice, we screened we only accepted an agreement with a patient who was a low-risk patient. So we would go through all the history, the physical, all the what we would call risk factors that were not appropriate for a rural hospital. And those people we would have to have the talk and refer them to a practice that had a higher risk, yes.
I mean, the diabetics, for example, I mean, if you're going to be, those, such trouble.
We had, I lost my train of thought.
That's all right, but I do think that high-risk people, you need, when you can predict that these are the people who are going to have trouble, if there's going to be trouble, let's get them to a place where we can protect them. I think that's wise.
Yes, that's right. Well, and my thought just came back to me.
Yes.
And that is that through all of our careful prenatal screening and care and continued risk assessment throughout the pregnancy, when we got to the 3rd trimester and even up to early labor, there was still about 10% that needed transfer to a regional hospital. So that's an important lesson.
To know when trouble could be.
And to know how to screen, and that even with our careful screening and following the patients through their prenatal care, it's turned out things evolved, that they did develop risk factors. And
I think that's perhaps the error that some people make. They say, I'm healthy, everything's fine, it shouldn't be a problem. And most of the time it's not, but there are these times when there are things developed that nobody can predict. And that's the value of having immediate access, because when things when problems develop, they tend to develop in a hurry.
Yeah. The health of a community can be impacted by things that are not what we may think of as a medical. And those who are part of the healthcare community can be part of that therapy as well.
Shakespeare Garden. It was a disaster when we came here. It hadn't been watered, you just lived on whatever rain came, so it was not nice. Well, I met Kathy, and we got to talking and discovered that both of us loved gardening, and she was distressed when she'd gone to see Shakespeare Garden, she said, well, it's terrible. Finally, we decided that it was going to have to be a complete renovation. Every plot was going to have to be cleaned, weeds pulled out, everything, and it had to be mowed. The trees had to be trimmed. They were all out of hand, some of them hanging almost to the floor of the ground. We organized a group, and we would work up there on Saturdays, and then every time we had any holiday or something where we weren't involved as a family or something, then we would be up there with whoever would go with us. Tom would fix old furniture. There was furniture in the house, but it was old and terrible in most cases. And he would replace broken arms and things, legs and things. And he fixed up a lot of the furniture that is still in the house. Then we were fortunate. Someone from Springs went to college over in Brookings and was involved in the agriculture program. And he talked about it, about Shakespeare Garden. And they did a lot to help us. They would get plants for us. And I mean, you know, those plants were expensive. I think one reason that so much has been accomplished in Wessington Springs is because people have been willing to work together.
What a delightful lady, 100 years of age, sharp as a tack. Talk about the social capital of a community. I look at, I sang in your
opera house.
In your opera house as a choral group some years ago, and I watched people filing in, and then there are you two, and you guys saw me, and your eyes went, what?
You didn't warn us.
No, so you, but you were aware. You were an organizer of that part of that.
I was in on that too, yes.
Yeah,
it's
so that's, you know, I just
wonderful.
want, you know, what a thing for a community. And that's what you see in little towns like Wessington Springs and DeSmet and Arlington.
You can be involved in anything you want to.
Yeah, and it makes the difference for the community, and the spirit of the community grows.
Absolutely. I think the thing that I've found that I've really valued about Wessington Springs, and it's true of many communities, is a willingness of people to look at problems and work together to come up with solutions. We don't agree on everything, and we have a few squabbles every now and then, but basically there's been a strong urge, or not urge isn't the right word, a strong motivation of people to work together and to do things that are going to benefit the whole community. And that's very gratifying.
Speaking of the whole community, tell us all about the hospital and how it was developed in Wessington Springs.
Well, the first hospital in Wessington Springs was opened in 1947. My uncle actually had just finished training as a physician. He did a brief residency in St. Paul and came to Wessington Springs, and they renovated an old house. And and that was the hospital from 47 until 79, when we built what we still refer to as the new hospital, even though it's approaching 40 years old. And so now, and it was always my uncle's vision that all the health services in the community should be located in one location, or should be housed in a single location. And so over the course of quite a number of years, they built a nursing home, and then they built a clinic nearby, and then they built the hospital that tied those two together. And then since then, we've added some congregate living facilities and a dental clinic and the county nurses there. The only services that we don't have are the pharmacy services. Everything else.
You don't have a pharmacy?
We do have a pharmacy, but it's downtown.
Right,
It's
but not a pharmacy within the...
It's not within the hospital, no.
Now, there was a story about artifacts that were found during the old hospital, the first hospital, or can you tell me about that? Don't know?
I'm trying to remember. You may know more about this than I do.
No, I'm getting little words from
okay.
people who were there. But anyway, there's stories there, I'm sure.
Yeah, yeah.
And I think we should also say, you said your uncle, but it's important to say the name. Roscoe Dean was a well-known physician, family physician in Wessington Springs.
Now,
started a
about
wonderful
Roscoe Dean.
tradition.
Yes, I mean, he was
He was a
quite a
real
guy.
promoter for the community.
Is he still alive now?
No, he died about 10 years ago.
09.
Yeah,
09.
about 10 years ago. He lived into his 90s, but he
was a character.
yes, he was.
I knew him.
Okay.
Oh, good.
Yeah, he was quite outspoken, but he really pushed for. He was very proud of the fact that we had a two-way radio system that linked the ambulance and the hospital and the physician together. This was, 35 years ago, and that was a big development. He had a very close relationship with the Indian folks in the reservation at Fort Thompson. In fact, he saw a lot of them and was actually very appreciated and respected, and was actually inducted into the Sioux tribe.
Really?
And given a Sioux name. So
Wow.
yeah, so it was.
I think there's another factor about Uncle Roscoe that was important, and he had such good working relationships with the surgeons and other doctors in Huron who would come down and help him do surgery.
Yeah, they did surgery.
Some of it scheduled.
Yep.
Well, did Roscoe do surgery?
Yes.
They did some.
I
yeah.
mean,
the
he was
old
a family,
hospital.
the old family
That's
physician
right.
who
He
did absolutely
Right.
everything.
Right. And when I started practice, it was very interesting because I was trained in a very different era than he was, and our styles were different. And he recognized that, and he understood that probably it wouldn't work if we tried to practice together. At the same time, he was very respectful and very supportive of what Kathy was doing, what a different approach that I might have. And I learned a lot from him. And I think the thing that was most important, he always had a big smile on his face. He was always very energetic. And he had a tremendous capacity to give people the sense that they were being taken care of, that they were important and they were being taken care of. And I've learned since then how important that is. And I think it's something that is all too often missing in the highly technical care that we have today.
Say that in another way.
The
value of.
Well, the value that people need to have the trust that they're important, that they're being taken care of, and that their issues are the only thing that's on your mind at that point in time, and that we're going to do everything that we can to make sure that they do well.
That's a wonderful thing. It didn't surprise me, that you would be a doctor having a hero like your uncle. I mean, in my mind, my guess is that's got to be a big reason
It
why
was a big influence, yeah. And I didn't really decide on that till late. I didn't even decide if I was going to go to medical school till I was a junior in college. It was very late. I still thought I might go back to the farm, but it worked out well.
Yes, it's been a good experience. And then you met this lovely lady.
Yeah, I bounced around. I went to medical school actually in New York, upstate New York, University of Rochester.
Oh, really?
Rochester. So I went east, and then I went west. And
well, the University of Washington is very difficult to get into.
Yeah.
So what happened? You were in New York, and then you didn't like New York, or how did that?
Well, it turned out that, like I said, there were very few family medicine residency programs available, and there was a fellow at the University of Washington, or at the University of Rochester, who went to Seattle to start the program at the University of Washington. And so he was a fellow that we had great admiration and respect for. And so basically I followed him, and I applied and was.
That's where you did your residency?
Yeah.
What about, did you do the first 2 years of med school in South Dakota like I did, or did you go
No, I
directly
did all 4 years in
New York?
In New York, yeah.
Wow. So that was the harder way. We always knew those people as the ones who could get into med school outside of the state of South Dakota. So I was thinking about the rural experience of poverty and richness. No, in this United States, we know that there are the very, very rich, and that at the same time poverty is growing. It's worsening in this United States. And we know that sometimes that goes with certain ethnic groups. Mm-hmm. You had an experience in Kentucky. Tell me a little bit about poverty in Kentucky.
We spent 3 years in Leslie County, Kentucky, which, as I said, was an isolated and very poor county. It was a coal mining area, and what had happened is that the coal companies had come in and bought up all the land, and basically promised the farmers that ran or that lived there prior to that they would give them a job, except they did as long as the price of coal held up, and as soon as the price of coal went down, they'd close the mine and say, well, that's tough, you know, and there were no, and so there was a culture of poverty that evolved, and we saw a lot of behavior that was irresponsible. There was a lot of alcoholism, a lot of violence. It was a tough area in some ways, although we felt safe. But it was a violent community. It's not far from the famous Hatfield and McCoy feud. We were just a few miles from there.
Yeah, but so what you see is all of the trappings of poverty.
Yep.
And these were white people.
This was 100% Caucasian, 100% white, yeah.
So, I mean,
so we came back and we see things happening on the reservations, for instance, similar behavior that gets attributed to a certain ethnic group. And it was such a powerful experience because we had seen exactly the same thing in a group that was 100% white. So, you know, our conclusion is that it's the poverty, it's not the ethnicity that is the underlying problem. And poverty is, it really embedded itself in my understanding that there's so much more to poverty than just lack of money. And it's a whole mindset. And it's your willingness and ability to plan for the future and all these things that we just...
Well, they're trapped.
Yeah, you're trapped. People felt there was no future, so why should I save anything? Because it'll be gone tomorrow.
Yeah.
And it's just a hopelessness that just totally dictates some very disruptive and dysfunctional behavior.
Kathy, what's your take on that?
Well, from what I've seen, I guess I agree. It makes me, I don't have anything really to add. It makes me feel bad.
For the poverty, the people in poverty. To me, that's got to be and should be one of the political directions that our leaders should take, is to help us try to bring people out of poverty.
And it's so hard because the easiest thing is, you know, I think, well, we'll give them some money. Well, then the response is, well, they'll just blow it, you know.
No, they're lazy.
But somehow we have to build, I think education is the most important thing, but it's a very long-term commitment, and the returns are many years in the future, but we've got to make the commitment,
Mostly early childhood, I think.
I think so, yeah.
Many community members impact their towns in ways that reach far beyond their vocation. Being a health care provider is seldom a 9-to-5 proposition and can encompass much more than giving flu shots or fixing broken bones.
Dr. Tom is actually exactly the same. Him and my one sister were born the same day. Our mothers were in the same room at the hospital. So we've been very close for years, and also in things like 4-H and all of those kind of things, because his family was involved with that. When I was in the legislature, at that time, they wouldn't pay nurse practitioners, doctors, assistants with the same rate as they'd pay a doctor for doing exactly the same procedure. So they were influential. They asked me to carry a bill to do that. So mine goes back to, and we did. The bill passed quite easily that if you was going to pay it for a doctor, you'd have to pay it for those practitioners as well, because that would support the communities. And we can talk about the hospital, and of course that's where Tom and Kathy operate, was in the clinic as well. We can talk about the hospital being important, but that clinic is the day-to-day connection to people with just the common colds, the everyday maladies, the injuries that happen, the farm accidents. You know, it's clinic people that take care of those.
You know, it's pretty extraordinary for a town the size of Wessington Springs to have a healthcare campus like we have. All under one roof, to have a medical clinic, a dental clinic, a hospital, a nursing home. We also have apartments for folks that might need a little extra help too. And all of that under one roof in a town of 1,000 people is just amazing. It's no doubt in anyone's mind that the deans have always been such advocates for healthcare, advocates for rural healthcare, that the quality of that place, and then also the longevity and looking towards the future. They've played a huge role in that. Healthcare is such a different world when you're in a larger market. I grew up in Phoenix area. Most of my career has been in the Southwest in large metropolitan cities. So healthcare for me, if I was sick, I went to the doctor. If I needed something, but I always just thought of the doctor as someone who, they would tend to my healthcare needs, but there was always sort of a barrier between that. I was the patient, and they had a lot of patients to see, so maybe I would have a minute or two with the doctor, and that was it.
I just think that we take for granted it's probably the second biggest employer, maybe next to the school, maybe it's larger, I'm not sure. So it's a huge part of the community, and it's easily for us that's had it all our life to take for granted that health care is going to be there. But most rural communities of our size don't have it.
During the Christmas blizzard of 2009, a local woman who was also a nurse at Avera, Wisconsin, she went into labor. Well, highway patrolmen were trying to guide them into town. They live outside in the country, and they had a really hard time getting to town, but finally did. She had to walk while in labor. She had to walk about a block and a half to even get to the hospital because the roads were so impassable. Now, at this point in time, Kathy had already been retired for about 9 years. So when Dr. Dean and Kathy walked into the hospital, and they had to make several attempts to get there, Christy said that she just had a huge sense of relief wash over her. She said she had never experienced a midwife before in her career or with her 2 previous sons that she had. But she said that birth, even despite having to walk a block and a half in waist deep snow while she was in labor, was her best birth experience ever because of Kathy. That whole term Prairie Doc might sound a little corny to people coming from larger cities, but I really think that personalized care really encompasses and it shows the meaning of that name.
What a great story. I just loved hearing that. So you delivered that, you helped that woman deliver her baby.
That's right. That's right.
And you had retired 9 years, but of course.
What do they say? It's like falling off a chair or whatever.
It's not an old thing.
You just know what to do. It was
good. And
it was wonderful to experience a birth again, I will have to say.
Yeah.
Yeah. I did want to share with you, Rick, another thing that's been so pleasing in my life, my career as a nurse midwife. I have a pretty good ongoing relationship with a woman who had 3 of her babies at our hospital. She's from Fort Thompson, and we get back and forth every now and then, but I've been to 2 of their 3 high school graduations, and she also gave me a phone call and then a letter when her first grandchild was born. So that's been a great pleasure.
Being part of the reservation and helping people in that sense, and the communication that you had with that. I think that whole delivering babies is something special. I remember in my med school career, I delivered, I think, 13 or 16 babies, and a number of afterbirths besides that the residents let me have. Oh, you can do this afterbirth, Dr. Holm. Rick Holm. But what a special thing to be part of where a new baby is brought into the world. It's just a super thing.
It truly is. There's not much like it. I lost it again. So
no, but I was thinking, what I was thinking about was the article that was in the New England Journal of Medicine that talked about what we can do to make ourselves even better. Yeah. And from Dr. McKay, one of the family OBGYNs in Sioux Falls, ours, leading article, editorial in the New England Journal of Medicine this week. Tell me about that, Tom.
It was quite a, well, one of the really worrisome things about our healthcare system is maternal mortality. Women dying from childbirth is actually increasing, and that's very worrisome and very disturbing. And the lead article, the lead editorial in a recent New England Journal, which is the most prestigious medical journal probably in the world.
Absolutely agree with you.
Was focused on this issue and what we can do, and actually one of the authors was Kimberly McKay from Vera McKinnon in Sioux Falls, and that was very gratifying.
Yeah.
And I think it's a complex issue. Some of it has to do with basic access to care, people not getting the prenatal care they need, getting so that problems are identified and dealt with before they become a crisis. And the editorial was focused a lot on what hospitals can do once problems develop, and try to be sure that they're prepared to deal with these urgencies that sometimes come up very quickly and without much warning.
In a protocol way. I mean, here it makes sure that you've got your ducks in a row at every place. Did you get a chance to read that article or peek at that article by Dr. McKay and the others?
Yes, yeah.
And any take home that you think that would you add?
Well, I would like to know some of the demographics about the people that unfortunately died after childbirth.
Yeah.
Access to care is so important, and so we've got to find better ways to get people for prenatal care so that those things are not experienced.
It's really the prenatal care that makes most of the difference.
That's where you screen the people and try to figure out.
The experts say
what the needs
that
are.
of these deaths, at least 60 to 70% of them are preventable with proper care. And we know that it has to do with the healthcare services because there's a big variation between states. For instance, the state that has the biggest problems is Texas, and it's a border state with a lot of challenges. But California, just well, a ways away, but it's also a border state, actually has some of the best outcomes. So the approach that the state takes and that the health system takes is very important, and we need to understand that better and make sure that we provide the support for the kind of services that will help to reduce these really alarming statistics.
So here we are, a nice couple living, perking along in Wessington Springs, and a family physician doing the primary care, which is, I think, one of the more important jobs that we can do. I say the two most important groups, of course, are internists and family physicians.
Yep, I agree.
General internists. But somewhere along the line, you became tapped for the med pack. Tell me what the med pack is and how many years you did that job. That was a huge thing.
Well, it was actually. I've had a real interest in health policy issues for a long time, and was very active in it with a group called the National Rural Health Association, which is an advocacy organization that includes a whole range of people, not just physicians or healthcare providers, but community people and politicians and so forth. And so I was very active with them, and then there was great concern that rural issues were not being adequately represented on this group called MedPAC, which is a shortened acronym. That's what I was.
That's the word.
It stands for Medicare Payment Advisory Commission, and it's a branch of Congress that advises Congress on Medicare policy.
I mean, it's huge. I mean, it's probably the most politically important medical issue influence there. And everybody, through the years that I was in the ACP and the ASIM and involved, MedPAC this, MedPAC that, huge. I mean, who is this that is in this powerful group? Well, it's Tom Dean from Washington Springs, too. So what did you learn on that?
Well, I learned that Medicare is a very complex program. And I learned that it was a very good experience. It was a very challenging experience. And Medicare is a very important program. It's a huge program, much more complicated than I think any of us really realized. And we got deep into the weeds on a lot of issues. The group met 8 times a year, so almost every month for 6 years I was on it. I was on my way to DC and back again, so I spent a lot of time on airplanes, which I don't miss a bit. But I think the lesson was that in this country, which is a huge country, a very diverse country, to try to write rules that deal with the abuse of the system that we see in some parts without hurting people that are really trying to do a good job and need some support. And
give me that example that you gave earlier.
Well, when one of the big problems that we looked at was home health care. And home health care, it was clear from the data we saw that was a service, a benefit that was being abused.
In Florida, for example.
In Florida. The South has the worst, well, I have to say it, all the worst performing health systems tend to be in the South. And so as we tried to figure out ways to clamp down on these systems that we could tell from the data were clearly abusing the system, we actually caused several of the home health services in western South Dakota to close down because the restrictions that we put on trying to deal with this abuse actually made it impossible for these services that were not very profitable to begin with because they had to travel a long ways between visits and all those things.
It just didn't work for the, doesn't that, so we clamped down on the Floridians and it destroyed the home health services in western South Dakota. It just burns my bottom.
Yep, I hear you.
It's not fair.
It's not fair. And yet all of these regulations that drive us nuts, every one of them originated because somebody was doing something bad and abusing the system. I mean, it was so clear, and so
we can think about regional rules. Maybe that's some of the things.
And I think we have to change the incentives that are built into the system so that those decisions can be made on a local level, and that the people that are coordinating the care get paid for doing good care, not just doing more care.
That makes sense. Here at On Call with the Prairie Doc, we try to improve the health of our community through viewer education. But there are many other healthcare providers who do the same thing in their communities.
You know, I purchased the paper about 3.5 years ago. And so although my background's in marketing and PR and in healthcare marketing, you know, being on the other side of kind of what I sometimes like to say, the other side of the same coin between public relations and journalism, you know, I had a lot of questions when it came to writing news stories about healthcare, and he has been such an amazing resource for me, and I'm so grateful. He served on so many different national committees and boards and has such depth of knowledge when it comes to our national healthcare system, Medicare, Medicaid. You know, I think if maybe some politicians would listen to him and his take on what the true problems are with healthcare, we could probably be in a lot better position. You know, just last Saturday, he took time out of his day to stop by my office when I was working on a story to give me a few details about different statistics and trends. And, you know, like he likes to joke, his family gets a little sick of him talking about those types of details when it comes to healthcare, because he really enjoys talking about it. But I'm always a pretty excited audience when it comes to him talking about that. And I'm certainly grateful for his willingness to always share his wealth of knowledge with me.
Yep, there you go, the wealth of knowledge that you have. And because of that, you've been on this show a number of times, and we've talked about healthcare policy because of the MedPAC experience, but just your knowledge. And so we thank you for your perspective and the education that you provide.
Well, it's been a gratifying, I mean, as I joke, I find this stuff really interesting.
Yeah.
And my family thinks there must be some sort of character flaw there.
There probably is.
There probably is, because I find it really interesting.
Well, you know, you look at what is one of the major dilemmas in America today is that our healthcare quality is like no better, maybe a little worse
Not
than
as good as it should be.
Next 10 wealthiest countries of the world, and we are twice the price.
Yep.
And understanding that price issue is a very important one. So I was thinking that we could talk a little bit about that when we've got just a little bit of time to talk about really the things between the two of you. I mean, you've worked hard, both of you, doing a lot of more than 9-to-5 jobs. How's your relationship been? And what's happened in your family and so on? You're still together, obviously.
Yeah.
You know, as we get older and as we slow down, we say, how did we do all that?
Oh my gosh.
Because we don't have the energy that we had 20 years ago. But it was because we were both on call, and we would both sometimes get called in the middle of the night, and our kids survived occasionally when things were going to be drawn. We've even had times when aides from the nurses' aides from the hospital would go and check on our kids if we were tied up with patients in the middle of the night.
Send the aide over to check on your children.
That didn't happen very often.
I don't remember that.
But
I guess I was busy.
it did. You know, it was rare. It didn't happen
Yeah.
much. But those are the beauty of a small community, and I think that we've both felt the rewards, as Kathy has already alluded to, of seeing people and seeing things that go well, and understanding the challenges when they don't go well, and they don't always go well, and hopefully helping people work through those things. So, and I think that it's brought us together. I think it's fair to say.
I think we're still going at it.
We're still working at it.
Yeah. One thing I found that after 45 years of marriage is that he likes to read more than talk. So when we come to situations like this, when he talks and talks and talks, I think, I guess that's all right.
That's all right. You know, it's an interaction.
Yeah.
There's no question about it. And every human has we have our own flaws. But one of the flaws that I don't sense is in this family is the humanitarian caring, which I see as the most important thing that occurs with primary care, is the ability to love that patient, to try to bring them to wellness. And it really isn't the medicine so much.
No, it's the personal relationship. And as I had said previously, going into the grocery store or standing in a parade or going to a baseball game, if someone looks at me and says, "Were you there with my mom?" It's just, it's really a wonderful feeling. And women will say to me, "You know what happened 14 years ago on this day?" And I'll know they're talking about a birth. And so that's a joy.
The one
20 seconds.
The one stereotype is that small town doctors' phones ring continuously and they never get any time to themselves. And that did not happen in our community. I think our patients were respectful, and we were not abused in any way by being bothered at home.
Love you guys. Thank you so much for joining us.
It's mutual.
And now for the winner of tonight's Prairie Doc quiz question. What percentage of deliveries by nurse midwives take place in a hospital? Is it 20%, 95%, or 50%? And the answer is 95% of these deliveries are in the hospital. We'll be right back after this.
Welcome to your Prairie Doc Library at www.prairiedoc.org. Wherever you live or travel, you and your family can enjoy free and easy access 24 hours a day. Search for a specific topic. Browse through the television shows, radio programs, and blog page. You, your family, and friends around the world can learn from physicians and other health professionals answering questions on a variety of medical topics. Visit your Prairie Doc Library today at www.prairiedoc.org.
The term midwife or midwifery derives from Old English, mid meaning with, and wif meaning woman. The term, in its literal sense, describes the person who comes to be with the mother during childbirth. From the beginning of humanity and through the millennia, the birthing of each human baby was usually helped by a midwife. The midwife was the mother's female relative, a friend, or the village experienced woman who knew about the process and understood on some level what to do if problems ensued. Up until the mid-1700s, midwives delivered most babies until some upper-class women started wanting physicians to be present for the delivery because of perceived safety issues. At the same time, most physicians were male and most midwives were female, creating a gender-based rivalry between female midwives and male physicians. And that conflict still persists. In 1900, about 50% of babies in the U.S. were delivered by midwives, but by 1935, that number had dropped to about 15%. In the 70s, the feminist movement revived an interest in midwifery, which we see today. That trend may change, however, as now 70% of new OBGYN residents are women, compared to less than 50% just 10 years ago and much less before that. Pregnant mothers have many options from which to choose for help with their birthing experience. These include physicians, family physicians or obstetricians, certified nurse midwives, nurses with required specialty training and proof of competency, certified midwife, not a nurse but with special training and proof of competency, or lay midwives, someone who may or may not have had special training or experience. Her options for places of delivery now include a hospital, a birthing center, or a home birthing space. For our babies, my wife and I both elected to have our family physician do the deliveries in our local hospital. In this day and age, for the most part, babies will come out safely. But sometimes something can still go wrong, and this usually happens very fast. In the early 1900s, the death of the mother occurred in every 100 to 200 births, or 600 to 1,000 deaths per 100,000 births. Now that number is down to 15 deaths per 100,000 births. Because of the unforeseeable and sometimes catastrophic nature of birthing, until those 15 deaths are zero, I personally recommend having all births delivered by a highly trained and certified individual in a birthing center or a hospital. A big thank you to our guests, Kathy and Tom Dean, for volunteering to come to our studio on Yager Hall on the campus of South Dakota State University. The unique experience they brought was key to tonight's program. Remember, you can get a copy of my new book, Life's Final Season, at many libraries and at the retail outlets listed on the screen. It's been a labor of love, and I hope you enjoy it. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Hello to all. I am Dr. Tom Luzier, a practicing allergist in Aberdeen, South Dakota. Born in Kansas, I embraced the diversity of South Dakota. This diversity comes with a price: limited healthcare resources and information. The Healing Words Foundation, through Prairie Doc, provides an open, online, interactive, public broadcasting format for reliable health information. As a member of the Healing Words Foundation Board, I am asking you please to join me in support of this work, which is funded entirely by donations from you. Please consider making a personal or corporate gift to Healing Words Foundation, a 501c3. Go to prairiedoc.org and click on the donate button and make a valuable contribution. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. and with ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Services Committee,
Aberdeen Asthma and Allergy,
and Swift L Communications.